Then coming to matching the donor and the recipient, please understand that HLA matching is typically not performed by most centers while performing heart transplantation. Even though studies since 1990s have been recommending matching for a better overall outcome, but many centers believe that this is not important. And if at all you are performing a HLA matching, the DR compatibility is going to be more important, like in kidney transplants, compared to that of HLA-B compatibility. But interestingly, some studies have demonstrated better survival with HLA-A incompatibility rather than HLA-A compatibility. And the mechanisms of protection behind HLA-A incompatibility is beyond the scope of the current discussion. We're not going to discuss in this particular lecture. And if not HLA compatibility, then what is the most important criterion that determines the outcome in heart transplantation? That is the cold ischemia time. It remains the single most important criterion for stratifying risk in patients who are undergoing heart transplantation. And even though you don't need a HLA compatibility, you need a ABO compatibility though. In the sense, I'm not talking about a ABO matching, but ABO compatibility at least. In the sense, you know what do you mean by the term universal donor or universal recipient when it comes to ABO. I'm not going to discuss right now. So it's a very simple one. And one more important thing that you need to ascertain is the donor weight to recipient ratio, which should be in the range of 75 to 125% or within plus or minus 30%. So what do you mean by that? So you have to compare the weight of the donor heart with the recipient heart. And there should not be any gross mismatch. In the sense, if the graft is abnormally of smaller size or abnormally big, it will not match in the, it will not fit into the mediastinum of the recipient. So in the sense, if the heart is too big, for example, then the surrounding structures may compress on the heart and prevent the normal functioning and can result in graft failure. So that's why the size also is very, very important. Okay, so it should be within 30% on either side. Should not be abnormally big or abnormally small. So it should be matched with the recipient's mediastinal size. And coming to cold ischemia time, I told you this is the single most important criterion that determines outcome in patients who are undergoing heart transplantation. So what do you mean by that? First, let us assume a heart getting clamped. This is the donor heart. This is the graft that is getting clamped. So first you clamp the great vessels. So that is the time where the heart goes for ischemia. So till the time you remove the heart and place it in a cold storage solution, this will be called as warm ischemia time. From the time you clamp the great vessels until the time you immerse the heart in the cold storage solution at 4 degrees Celsius, it will be called as warm ischemia time, phase 1. Then the heart will be placed in a cold storage solution, right? Heart will be placed in a cold storage solution at 4 degrees Celsius. This is what we refer to as cold storage, traditional cold storage. And the time the heart remains in this cold storage solution is what we refer to as cold ischemia time. And the acceptable cold ischemia times as of now is less than 4 to 6 hours. The lesser it is, the better the overall outcome is going to be. And then once again, the time you remove the heart from the cold storage solution, your warm ischemia time number 2 starts basically until the time you establish reperfusion. Okay, let us assume this is the time where you're going to attach the donor heart with the recipient's great vessels and you're going to establish the blood flow back to the heart. That is called as reperfusion time. Until that time, it will be called as warm ischemia time, phase number 2. And if you add both these together, you will get the total warm ischemia time. Okay, both 1 and 2 if you add, you will get the total warm ischemia time. So now you can understand what is warm ischemia time and what is cold ischemia time. And as I told you, the accepted CIT is approximately less than 4 to 6 hours at 4 degrees Celsius. And some studies also have demonstrated the importance of warm ischemia time, even though it is highly questionable. Many studies have not demonstrated this, but very few studies have demonstrated that if warm ischemia time is less than 45 to 60 minutes, then it improves the overall outcome as well. And what are the preservative solutions that we use right now? One of the oldest solutions is University of Wisconsin solution. Then we have another newer solution that is called HTK solution, that is called histidine, tryptophan and ketoglutarate solution. And we have some modern solutions like Celsia solutions as well. But in exam, you need to know at least the University of Wisconsin solution. And another newer technique that is available for preserving the heart and transporting the heart is called as organ care system. It is devised by a unit called as Transmedics, that is also called as heart in the box system. So what do you mean by OCS? This is a very interesting system in the sense the heart is not kept in a cold storage. Usually if the heart is kept in a cold storage, it will not be beating. Then after, connecting to the recipient great vessels, then it will be electrically stimulated to make it start beating again. But in this system, the heart will be still beating at the time of transport, and it will be stored at body temperature, that is 37 degrees Celsius, and you're going to perfuse blood and preservative solutions into the heart, so to keep it alive as long as possible. So technically speaking, it is a beating heart in the box even during the time of transport, unlike your cold storage system where the heart will not be beating until be in the cold solution at 4 degrees Celsius. So it's a very interesting system. This is a very recent system, and people believe that it can increase the time to transplant, in the sense the transport time can be increased. So rather than keeping it as routinely as less than 4 to 6 hours, it can be a little higher, but we don't know exact cutoff as of now. But it can be higher because it's stored at 37 degrees Celsius, and the injury to the heart during the time of transport is going to be very negligible, at least theoretically. And the number of heart transplants that's been done over the years, in the last 5-10 years, if you take, has been very flat, in the sense it's not increasing at all. That is because of the cold ischemia time. And that is because of the difficulty in transporting the heart, because it has to be done within 4 to 6 hours. But because this can potentially increase the time to transplant, it can potentially increase the number of heart transplants overall. So that's a probable, USP of this device. And very recently, FDA have approved this organ care system device, and that is based on the results from EXPAND trial, which clearly showed that results with organ care system are comparable to that of traditional static cold storage in terms of morbidity, mortality, and overall long-term survival after heart transplantation. Plus, it comes with an added advantage of potential increase in the time to transport and time to transplant, which I have discussed already. And coming to the properties of the graft is basically denervated. It doesn't have sympathetic nervous system supply also, it doesn't have vagal supply also. So the resting heart rate will be somewhere around 90 to 110 beats per minute. You, me are having good SNS and vagal supply, so the baseline heart rate will be somewhere around 60 to 80 or 85 beats per minute. That is because of the slight overactivity of vagus compared to that of the sympathetic nervous system. But when you remove both the sympathetic and vagal influence out of the heart, the resting heart rate will be somewhere around 90 to 110 beats per minute. So what will be the denervation and the renervation rates? It depends on the surgical technique also. First, let us talk about the denervation rates of SNS and vagal fibers in biatrial technique and bicaval technique. Remember, it's almost going to be 100%. Okay, in bicaval technique, it cuts off all the fibers almost, whereas less than 10% of the vagal fibers are removed in the biatrial technique, which means most of the vagal fibers are preserved in the biatrial technique, and almost 50% of the sympathetic fibers are removed in the biatrial technique. And what about renervation? After bicaval technique, vagal renervation is going to be very, very poor. Okay, that is usual. So even at 14 years of follow-up, they did not show much of vagal renervation. But sympathetic nervous system renervation can happen. Approximately 1/3 of patients have a patchy renervation at approximately 1 year, which tends to continue until 14 to 15 years. And this renervation will be usually heterogeneous and patchy. And one more important thing to understand is the heart doesn't only have a resting heart rate of 90 to 110, it doesn't respond to exercise also too much, because the heart rate response to exercise will depend on the sympathetic nervous system, and of course to some extent on the parasympathetic nervous system also. Because after bicaval technique, which is commonly performed, the heart is completely denervated. You won't get a heart rate response to exercise also, but maybe after 5 or 10 years, patients can have a partial restoration of the heart rate response to exercise because of some kind of renervation from the sympathetic nervous system side, but still there is very poor renervation from the vagal side. When it comes to biatrial technique, once again you have a poor renervation from the vagal fibers. That is because already there are a lot of fibers that is left. There is no need for renervation. So that is the idea here. Plus at the same time, there is a poor renervation from the sympathetic fiber side also. That is because a lot of fibers are already left. So that is the reason. So if you ask me which will result in best sympathetic renervation rates, technically it is bicaval only, because almost all the fibers are removed. That becomes a stimulus for sympathetic fibers to regenerate. That's it. Plus, of course, the heart rate response to exercise will be very variable. Immediately after the transplant, it will be very, very poor, but over time it might improve. And one more important thing is the fact that angina is very uncommon in the graft and in the patient who have a heart transplant, despite the fact that the grafts may go for significant ischemia. That is because you don't have SNS system which carries the pain stimulus and causes that kind of referred pain. So angina is very uncommon in the graft. And patients are over-reliant on the circulating catecholamines. Plus, at the same time, you need to know about the effect of the drugs on the graft as well. So first, atropine digitalis, which works by the principle of stimulating the vagus, or it works by vagomimetic principle, will have absolutely no effect on the denervated heart. But on the other hand, drugs like adenosine, beta agonists, and beta blockers will have an exaggerated effect. That is because of the receptor upregulation secondary to denervation. This is something we all know.